speaking of PSMAfore,
Yeah.
now that we can use it pre-chemo, are you offering it to everybody pre-chemo now that we can do it? Or are there...
Honestly, I mean, it might be these guys, the urology guys, that start using it, because they have an active, at least at Tennessee, we have an active program where they administer the RPI themselves, and so it might be them referring patients for Pluvicto is I think where this could be going. That's good. Yeah, I mean, I think that there are patients I think that come to them. We hear them about intramural all the time. These guys just they don't want to be on chemo, and it's something that gives them another option. But.
Yeah,
certainly a stigma at least around chemo, right? I mean, when I moved to East Tennessee and they hear the word cancer, they want it cut out, and then they hear the word chemo and they're like, I don't want to lose my hair. And so there's a stigma based on that. And if you look at the treatments, these patients have toxicities with lutetium. So when you mention alternatives, I think patients, at least locally, anecdotally, trend towards, I don't want to get chemo. So I have a few patients that have been sent out for lutetium treatments, and they've done well. I think now that it's available in the pre-chemo space, Dr. White and I treat a fair amount of advanced prostate cancer with ARPIs and up to the point of chemo, and I'm glad we have good working relationships with our medical oncologists in town, because it is a team sport. And so it's all about finding the right fit for the patient, both from a treatment standpoint and from a socioeconomic standpoint, certainly around here. And so I'm excited about the pre-chemo treatment. I don't know how to sequence it yet.
Don't underestimate the direct-to-consumer advertising. I mean, it was heavily saturated during the Olympics and targeted during football games. Patients are coming in actively requesting it, even if it's not quite appropriate for them, and so it initiates the conversation probably at an earlier point, and they're not perceiving it as a true systemic therapy.
Sure.
Yeah, I think there's a caveat there too, right? Like when you look at how these trials are designed, so PSMAfore has a control group as switch A at RPI, right? Is that the right move through medical oncology? Typically, we think that that's a strategy we sometimes are boxed into, but we've got chemo and other things that might typically be a standard of care after a prior ARPI. So, I'm sure there are some caveats and there's some people who probably look at it a little bit differently in what those groups were.
Then with these men who have comorbidities, some of right up to, they're not candidates for chemotherapy. And so those patients, we certainly would refer for lutetium at that point, because they will not be able to do chemotherapy.
Sure. I feel like 5-7 years ago that was the move, right? You started them on ARPI and you switched them. And I think if you look at the data, maybe 20% of people.
Yeah, well, and at 20%.
But PSA reverse by hands. So
usually happens in the first 3 to 6 months, maybe, right?
Yeah,
sure.
And so nowadays, whenever I see a patient start to fail an ARPI, I'm either they're going to a medical oncologist.
Right.
That's the next step. They need to, if they haven't had triplet therapy or taxane-based therapy, they need it. Right. And then this gives us another option.
Yeah, it does. It certainly opens up another option. Absolutely.
Yeah, I think unanimously patients would prefer something like that over chemo. But what if the patient had liver metastases? What if the patient had SUV values that were modest, less than 10 per vision trial?
So that's an interesting group.
We're going to medical oncology.
Yeah, right. So yes, liver metastasis already you're looking at a high risk grouping, right? And then I think what you're referencing is the therapy study that looked back at SUV mean less than 10, and so those patients may not have done as well. It didn't mean they didn't benefit at all. We think we did maybe see some benefit in that group, but as a whole, that group seemed to do less well than the patients with the mean SUV above 10. I will tell you, even at an institution like us, that that maybe larger institution around the area, we don't report mean SUVs, right? So some of it is just about if there's 5-6 lesions with a very high SUV, you say, okay, well that seems like a high mean SUV, and you kind of go for it.
Oh, speaking of which, how do you guys assess benefit from lutetium PSMA? Are you guys doing interim PETs like we do with lymphoma, or?
So I've treated a few patients with it, and I mean ideally, the challenge is looking at the Vision trial, they did kind of conventional imaging as their kind of interim assessment. But I personally feel it's a PSA positive indication. So a PSA PET scan, I think, should be the gold standard in terms of monitoring these patients. I would prefer to, typically, I've tried to get after 2 cycles.
Sure.
And see, but today insurance will deny that. And then obviously with the med-onc colleagues, we monitor, and our urology colleagues monitor their PSA and see what kind of response they're getting.
And one point I was going to bring up was, I think in that vision trial, I think they used like PSMA avid, but FDG negative as some of their group, right? So how many of us are getting 2 PET scans on patients too? Can we kind of get one approved correctly, right? A lot of times, and so I think it's challenging applying sometimes the trial data to real life, unfortunately.